we should just...
I don't know whether they want to come in or not.
Yeah.
I don't mind them coming in while I start.
All right.
So
We just start with our first speaker, who's John Sear from Oxford, who's going to give us an update on why should I give Propofol via TCI. We agreed on having a major discussion at the end of the speakers, but we may ask some questions in between.
Okay.
Yeah?
That's good.
John.
Thank you very much indeed, Sharon. For those who saw me fall over a minute ago, the problem is I landed on a leg that's got no cruciate ligaments. My knee gave way as a result. Can I thank the audience and thank the Society for inviting me to speak this morning. I realise I perhaps ought to have put down as a disclosure that I was responsible for giving the first dose of Propofol way back in 1983. I don't know if that's a disclosure or not. I was given this question, and I'm therefore going to try and look at it in the following manner. I'm going to look at the history of how TCI Propofol has developed. Secondly, I'm going to look at what the components of a TCI system are for those who are not totally aware of the components. I'm then going to talk about the performance of the systems. I'm going to talk about some limitations of the systems, and I'm going to pose some questions right at the end. If we go back to the first background premise, which was that prior to the introduction of TCI and really clinically in the mid-1990s, many groups represented by people here this morning used empirical infusions at rates between 6 and 12 mg per kilo per hour. In the late 1980s, the group in Bristol, with Priest Roberts and colleagues, devised this manual system, and the aim was to produce a propofol concentration which was associated with that concentration needed to provide adequate surgical anesthesia in patients also receiving opioid or nitrous oxide supplementation. But the problem that was developed and identified by that strategy was you had to work out how you could rapidly increase or decrease the achieved drug concentration to increase the depth of anesthesia. Similarly, increasing the infusion rate wasn't adequate because it took time to establish a new steady state concentration. Obviously, one system that was logically applicable was to give an additional bolus dose of drug. Now, if we look at the history of TCI, and there are some people in this room who are intimately involved in that, I will mention as we go along. The first mathematical approach to the concept of TCI was published way back in 1968 by Kuger-Kramer, which is in the European Journal of Clinical Pharmacology. But it's the group who were previously in Bonn, Hermann Schwilden, Jürgen Schüttler, who first described the clinical use of it. And if I'm correct, Jürgen, it was using etomidate and alfentanil. I think that's the first report I can find. There have been a number of different systems published, all based on this same BET scheme. And the abstract that I've prepared for you, I think, lists some of them. The DIPRIFUSOR system was the first commercial system generated and was based on a 3-compartment mammillary model using the data of Marsh and using tagged propofol syringes. Now, the basic concept is easy. Drug concentration equals infusion rate divided by drug clearance. Now, that's for a plasma drug concentration. Unlike the fixed infusion regimens that I described earlier, TCI was developed in order to easily increase or decrease the required target concentration, therefore improving the titratability of the drug. I'm going to pass on that slide. Now, the principle was very easy. The first thing to remember is that the target concentrations are calculated and not measured. That the TCI pump, therefore, is programmed to deliver 3 superimposed infusion rates. One is a constant rate to replace drug lost by elimination. Secondly, to have a a rate that is exponentially declining to match the drug that is passing from the central compartment to the peripheral tissues of the body. The third phase being the bolus dose in order to induce anesthesia, which is mathematically determined as the drug concentration times the initial volume of distribution. At present, there is no clinical method which is reliably available to measure real drug concentrations in time, although I will come back to that towards the end of the talk. So you have no analogous situation to the end-tidal volatile concentrations you can measure for volatile anesthesia. Here we have the, if you like, the block diagram, patient details fed into a microprocessor, which drives an infusion pump, which goes to the patient, anaesthetist assesses response, and therefore you've got a feedback, but it depends upon the anaesthetist there in order for feedback to occur. Now, the TCI systems, for those who are not familiar, and that should be everybody in the room, other than those in the US, should be familiar. It's pretty well ubiquitous everywhere else. But as far as I can work it out for you, a calculator is a software program, data sets of various pharmacokinetic parameters, the infusion device, and a user interface. Now, the main benefit that is reported of TCI over manually controlled infusions is the selling point, if you like to put it that way, is that there is greater and tighter control of drug concentration and therefore control of the depth of anesthesia. Professor Leslie has very kindly, at the end of the talk, we'll see her data of a Cochrane collaboration report being used to question that statement. Now, for historical purposes, let's have a look at some early computerized delivery systems that were used to deliver Propofol. If I get this right. This is the Bristol system, which was driven by a, well, that looks like a BBC computer to me. And it was a BBC microprocessor and which contained the pharmacokinetic parameters, and that actually drove an infusion pump. The next The next system was, I think this is an early Gavin Kenny version from Glasgow. Anybody who's worked in Glasgow may recognize it, but that again is using an ordinary laptop computer through an RS-232 interface to drive the anesthesia infusion pump. The next one were a number of systems which were driven to drive the Ohmeda 9000 syringe pump, which had a bolus rate of 600 and 1200 mils an hour, and a variable infusion rate, which could be between 0 and 200 mils an hour. This was the system that Gavin Kenny in Glasgow adapted to provide one of his first portable target-controlled infusion systems. And there is Gavin looking at, while somebody else does the anesthetic, I suspect. And just to prove that it's in real time, that is the output interface. And with a bit of luck, we've got the syringe pump down there, and it's all rather stacked together on a trolley here, and this is going back to, it looks like the BBC system again. He is not asleep, he's just showing himself to be a willing subject for demonstration purposes. Now, the real question is, these were laboratory setups, therefore were not suitable for use with a commercial TCI system. With a TCI system, the anaesthetist doesn't control, this is obvious, the device's infusion rates and the size of any bolus doses. Rather, he/she titrates the depth of anesthesia by selecting a target drug concentration appropriate to the clinical scenario. And there's a number of different algorithms that have been used to achieve this. The DIPRIFUSOR system is made up of two separate processor systems. There is a 16-bit processor which drives the predicted pump rate. It's a real math solution, and the drug concentration is either 1 or 2%, depending on what you put into the system. There is a second processor, which, if you like, is a check system to make sure that everything is going properly. It was an 8-bit processor. It looks at the actual pump rate. It looks at the approximate solution for the maths, and it again uses a known drug concentration in order to achieve the output solution. The unique feature, I think, of the DIPRIFUSOR system was the tagged recognition system, which was on the syringes, which were used in the system. And if I've got this right, we shall see that in a moment. Now, I have tried to summarize what I think the initial DIPRIFUSOR system gave us. It gave us a model for the use of TCI in adult and elderly patients, and it was based on what I would call middle-age kinetics. I looked at the data of for the Marsh kinetics, and they are what I would call middle-aged patients. I'm not defining that. There was no guidance as to the influence of patient weight in neonates and young children, nor how well the system would function in the obese patients. And therefore, a number of groups, some of whom are represented in this room today, started to look at the issue of what is the best correlate to provide the best infusion system. Does it depend on weight, surface area, or lean body mass? Because the algorithms of the data were based on a relatively small number of healthy patients, which were then extracted to a general population, you'd expect to see a variability in the end result if you measure the observed rather than the predicted drug concentrations. And quite clearly, you would expect that the system would be less accurate in conditions of extreme clinical conditions, such as shock, hypovolemic patients, in intensive care units, and in conditions where there was considerable blood loss, in severe hypothermia, where there were temporary changes in the composition of the plasma, for example, conditions where there was hyperalbuminemia, and in patients where there were significant comorbidities, renal failure, advanced liver disease, acute liver disease, chronic liver disease, burns, and obesity. And therefore, the first observation I would make is that starting off from the DIPRIFUSOR system, we have, in order to make this system predictable, we need further data which allows us to modify our infusion strategies in these different and extreme scenarios. These are the DIPRIFUSOR pumps that I could find a collection of: the Graysby pump, the IVAC TCI pump, and I think that's the master system. Somebody can correct me. I believe that's a French system, but I'm not sure. The bottom one. Oh, yes, of course. Right, it is. Now, there are, as I've indicated, there are a number of different data sets that are available to include in the various pumps in terms of the kinetic values. The DIPRIFUSOR, the initial DIPRIFUSOR, used data, the so-called Marsh model. Now, one of the problems with the Marsh model is that it was the data was put in and it was subsequently adjusted, because I know where the original data set came from. But I would criticize the Marsh model, if only because, as we shall see in a minute, the derived pharmacodynamic model which goes with it was not achieved at the same time as the original kinetic data. There have then been subsequent models, one by Jürgen Schüttler and his colleagues, which was a population model. What I call the White-Kenny model, which was published in 2008, where there were a number of covariates. And of course, then there is the Schneider model, which has a number of covariates. For pediatric use, there's the Kataria model and the DIPRIFUSOR model, and I believe there's another Japanese model as well, but my Japanese is not up to that. Now, each of the different pump setups use a slightly different combination of pharmacokinetic and pharmacodynamic models. So you need to know what you're getting for each system if you're going to use it. But one feature which is useful of all the current TCI systems is that they allow the anesthesiologist to have an approximation of what I would call the relevant and effective decrement time. How long is it going to take for the drug concentration to decrease when you've turned off the infusion? And from this, the anesthesiologist is allegedly able to accurately predict the offset of the drug. However, the problem with that system, with that calculation is that it takes no account of drug interactions. I know that Michelle will talk about that in the next talk. It takes no account of comorbidities, and it takes no account of concurrently administered drug therapies. Now, the algorithms used in the various TCI systems, we're now going on to the interface between kinetics and dynamics. The original DIPRIFUSOR system had a KEO of 0.26, and the open systems that have subsequently been developed have either used the same KEO value or a different KEO. The DIPRIFUSOR in the base Premier system has a KEO of 1.21. The Schneider model has a KEO of 0.465. There are important things to remember as to why there are different KEO values. The KEO in the DIPRIFUSOR system was established by Valérie Bienert and colleagues, and looking at their paper, which is in Clinical Pharmacology and Therapeutics, they used the relationship between drug concentration and spectral edge frequency, delta power, and the BIS. The Schneider model used a similar analysis of for looking at the effects of the drug, but they have the advantage of having simultaneous kinetic and dynamic data from which to model, or with which to model. Now, are there differences between the two models? Come on. If we look at the kinetic differences, first of all, the Marsh model is only weight dependent. That's the only variable you can change. And the kinetic model, these are data for a 70 kilogram average man. V1, 15.9 liters, V2, V3, and that gives you a clearance, which is going to be 0.119 times 15.9 liters per minute. The Schneider model, on the other hand, has 4 different covariates: age, weight, height, lean body mass. And that actually gives you a different calculation for clearance, but it's not statistically significant. The KEO value, as we've already said, 0.26 for the Marsh model and 0.456 for the Schneider model. The time to the time to peak effect on the basis of the Marsh model will be about 4.5 minutes, and for the Schneider model, it's been worked out to be 1.69 minutes. Now, in the Marsh model, as we said, the compartmental volumes are weight proportional, whereas the rate constants are fixed. In the Schneider model, there's a smaller V1, larger KEO, and the effect site concentration will therefore fall faster on stopping the drug infusion. And you would therefore expect that if you gave the same patient the same anesthetic by the two approaches, that the Schneider group, or patients receiving the Schneider regimen, would wake up faster. That is quite clearly a study that can never be done, unless you can find a population of patients who are going to have the same surgical stimulus, the same anesthetic regimen on 2 occasions, and you can then do the study. The Schneider model, V1, V3, the rate constants are fixed, whereas V2, according to their report, is influenced by age. Now, we've said there are different algorithms for children, and because of these variety of algorithms and kinetics and PK/PD results, there has been an attempt to try and put everything together to identify the best model with the most identifiable covariates. And I would bring to your attention something called the Open TCI initiative, which was started from a meeting in 2008, if I'm correct, in Copenhagen, which had 3 functions. Firstly, to list all the pharmacokinetic models that there were. Secondly, to provide a common raw data source for other people who wanted to try and derive additional features which might be important in the safe and effective delivery of TCI anesthesia, and was also thought of to be a forum for discussion. I'm not quite sure how these areas have all stood up to time and whether they've achieved all of their aims. The other thing that had happened at the same time was, of course, the introduction of generic propofol, where you didn't need to have the tag syringes to link in with the DIPRIFUSOR system. So we've therefore got a number of systems, a number of different kinetic models, a number of different PK/PD relationships, and it's therefore appropriate to ask the next question, which is, if you've got all these systems with these different kinetics, these different patient populations, how well do they function? The system for performance of TCI systems is based on the work of Varvel and colleagues in 1992 or 3, and these are basically the 4 parameters: bias, accuracy, wobble, and divergence. Now, the second factor that has come into play with our ability to understand the way that drugs act has been to target not the plasma or the blood, but the effect site, which of course is where the anesthetics act. Whether they affect the midbrain, the hindbrain, or the forebrain, go back to the first talk this morning. And the consensus of opinion of the performance of these systems was that for a system to be reliable and clinically useful, it should have a median absolute predictive value of less than 30%, and a median predictive efficacy of error, rather, of plus or minus 20%. Now, I've chosen a random selection of issues which might influence how well these various TCI systems function. Choice of kinetic model, choice of blood-brain equilibration rate, the fact that the models were based on ASA 1 or 2 patients, and most people these days are anesthetizing patients which are far from ASA 1 or 2. Influence of disease or drug therapies on propofol disposition, the effect of weight on PK/PD models, and the one factor that still needs a lot of consideration is the effect of age, not only on the kinetics and the dynamics, but also on the associated PK/PD relationship. If we look at the time to peak effect, and we compare it with the KEO values, we can see that propofol has got a KEO value in different studies between 2 and 6 minutes, depending on what the measured effect parameter is, and that a time to maximum effect after a bolus dose occurs at about 1.5 to 4 minutes. What we're looking at is if you take a bolus dose of propofol, and we are measuring here a number of different effect site parameters. First of all, it depends on the various calculations, and we'll see if we can get these in the right order. The black line is with the Schneider model and effect site concentration, where there is a peak at 1.6 minutes. The Marsh effect site calculation with a peak at 1.6 minutes, which is the blue plot. The Marsh effect site concentration with a T to peak of 2.5 minutes, or 2.3 minutes rather, here. And the Marsh model used for the effect site concentration, the KO of 0.26. And you can see the time to peak concentration. Therefore, the time to peak effect varies according to these different pharmacokinetic and pharmacodynamic parameters which you put into the system. Now, the thing to remember is that the time to peak effect site concentration is dose independent. If you give a supra therapeutic dose, you get there faster than if you give a therapeutic dose, because you are, if you like, overshooting the system. But the time to the peak site concentration depends on the rate of equilibration and also on systemic drug kinetics, and I shall come back to that in a moment. Notice not necessarily the time to peak effect site concentration is not necessarily the same time as the time to peak effect, because as I've indicated just a minute ago, you can achieve an earlier peak effect by giving a supramaximal dose. Let's think of some variations in pharmacokinetics which may affect the accuracy of your TCI output. First of all, drug concentration assay errors, inadequate mixing at high infusion rates. Is there any evidence that there is dose-dependent kinetics for propofol? Technical errors within the administration system or errors with the delivery system, and obviously this patient variability. Come on. I tried to ask a question, first of all, as to are the kinetics of propofol linear? Now, if I was to ask for a show of hands, I would estimate that about 70% of people in the room would say they are linear, and there'll be 30% of people who can say yes, but there's a study that shows that it's non-linear. By and large, if at infusion rates between 25 and 200 mics per kilo per minute, they are linear. But we have shown in an open-chested dog model, Jürgen Sear, Jürgen Schneider, and Dr. Carita, if you dissect their data out, you can all see that they show a concentration effect on drug clearance. And if we look at the next overhead slide, this is our own data in this open-chested dog model, where we infused 200, 300, 400, and 500 mics per kilo per minute to the dog. We achieved steady-state concentrations. In the second column, we measured cardiac output, which you can see as the concentration rises, cardiac output falls, and we can see that there is a decrease in ICG clearance, which is a marker of hepatic blood flow. So therefore, if the hepatic blood flow decreases by 50% from the value at 200 mics per kilo per minute, which is the dose that's very roughly equivalent to producing a concentration of 6 to 10 mics per mil in man, up to 500, 2.5 times, you can see we've halved the hepatic blood flow. How well do the various kinetic sets predict the concentration. Anybody who feels their data has been neglected on this slide, I apologize. Just took a random selection. These are all data based on the Marsh kinetic model, and unless Thomas is going to tell me afterwards, I don't think anybody has done a predictive assessment of the Schneider model. There may be a paper in the Japanese literature or one also in the Brazilian literature. My Spanish is not up to it. Notice that the variability, the bias and the inaccuracy of these various data sets ranges from very good to, I'm afraid, this data set, which comes from this town. It's got a high median predictive error and a high absolute predictive error. Our own data in young volunteers shows a data set that's representative of other people's work. Now, other causes of variability, I've mentioned some of them already: age, obesity, hypoalbuminemia, and plasma, which may affect plasma protein binding and therefore in turn drug clearance. Anemia have never been considered in any model so far, and obviously conditions with impaired cardiac output. Online drug concentration. If you could measure the propofol concentration online, would it help? Now, I've posed some questions. Well, it's not available at the moment. That's not true. There is a system which has been released called the Pelora system, but there is a need for a number of trials and for proper evaluation of the system, and also its utility in helping to deliver appropriate TCI anesthesia. Second question: knowing true drug concentration would not allow if knowing the drug concentration would not allow the effect to be more accurately predicted. This is not true. It would be possible to take the data that you've got and to modify your input rate based on Bayesian modeling. As I've already alluded, present kinetic models are based mainly on ASA 1 and 2 patients. We need to have more data from people with more severe underlying medical conditions. No, there is no one single blood concentration which will allow satisfactory results for anesthesia in all patients for all types of surgery. That's true, but then there's no one entitled volatile concentration either. Now, if you go back to 2008, I'm sorry to embarrass the good lady who was responsible for this, Kate Leslie and her colleagues produced a collaborative report for the Cochrane collaboration, and the title of it, which doesn't come out very well, Target-Controlled Infusion versus Manually Controlled Infusions of Propofol for General Anesthesia or Sedation in Adults, brackets, a review. It was revised in 2012, and I accessed the data in March of this year. Now, the concept that was put forward initially was that TCI was expected to avoid overdosage, ensure constant concentration and therefore constant effect, to allow accurate titration, and to take into account some patient covariates. When we come to assess the data to see whether TCI works effectively, is better than or the same as other methods of drug delivery, we are down to 26 randomized controlled trials, of which 6 were excluded on the grounds that I've listed there, 2 because there were extra bolus doses, or 1 was TCI versus bolus doses, 1 was non-randomized, 1 had different adjuvant drugs to the 2 treatment arms, and 2 had no outcomes. So that should give us 20 RCTs. I quote the author, 20 trials of poor quality. There were 1,759 patients with high heterogeneity of patient age and underlying pathology. Note that 2 of these patient papers have subsequently been retracted. I don't know quite what that does to the 1,759. I think it takes off about 120. The results. TCI is actually associated with higher, not lower, total drug dosage of propofol, but was associated with fewer interventions to provide adequate anesthesia. Use of TCI was not associated, or there were no clinically significant differences in the quality of anesthesia or in the incidence of adverse events. You therefore have to ask, is that a true assessment? Or, as I believe, that probably the answer is, there's not enough data to assess the utility of TCI in different patient groups with sufficient number. What other uses are there for TCI? Well, it's been used for intraoperative and postoperative analgesia, for patient-controlled sedation, and it's also been used as a part of a closed-loop system called CLADS or CLANS for closed-loop control of anesthesia. I want to come and therefore summarize and come to my last 2 or 3 slides. So the rationale is easy. TCI is based on the premise that concentration equals infusion rate divided by clearance. The utility under which it was initially promoted, easier to titrate drug concentration to stimulus strength than by manual dosing. That is probably true. Questions. Which kinetic model is the best? We've already highlighted that there are a number of kinetic models which are based mainly on data from small numbers of ASA 1 and 2 subjects. The kinetics have been derived from different sources, from different assay departments, some in patients and some in volunteers. The variability in kinetics and dynamics will also be made larger by the presence of disease, aging, or intercurrent therapies. We know that overdosing with TCI leads to cardiorespiratory side effects, while underdosing has the potential for awareness in paralyzed patients. The different kinetic models, it's difficult to compare them and to come to a consensus over which is the correct one for which group of patients, because they all have different values for volumes of distribution and for the KEO value, and that KEO value was not uniformly derived based on a constant stimulus or stimulus parameter in all the studies. Is TCI better than MCI? I would just summarize it by the last sentence. The results from the 20 randomized clinical trials and the 1,759 patients were not completely as expected. Now, how can we possibly improve the use and the utility of TCI? Well, I've already suggested that the online drug concentration measurement and Bayesian modeling may be useful to adjust input rates to observed drug concentrations. But that depends on your being able to measure drug concentrations online in real time. The basis of the present technology needs to be assessed further. You might want to also help to titrate input rates to a dynamic endpoint, such as using the EEG, evoked potentials, or other effect monitors. Should we, rather than using a set of kinetic data generated in, I think it's 11 patients for the Marsh model and 20-something, I believe, for the Schneider model, should we in fact be using population models based on larger numbers of patients in order to define pharmacokinetic confounders more fully and to derive an ideal data set for different patient groups. There are some elegant studies that have come out of Japan which suggest that KEO may vary with age, but does it vary with disease? You therefore come up with a number of positives and a number of negatives. If I had to summarize the situation as I see it, the Marsh model, using the Marsh model, is probably appropriate for plasma targeting. It's not so good for effect site targeting, and it has the potential to cause overdosage in the elderly and in the obese patients. Thomas Schneider's model is quoted as being not suitable for plasma targeting, and there are again problems with their model in the obese patient or in the calculation of lean body mass. And I'd refer to a rather nice review article which Tony Absalon wrote in the British Medical Journal in 2009, which shows that you get to a point, an inflection point on the curve, whereas the patient's size increases so that their apparent dose requirements to achieve a given concentration falls. You need to read it to understand the argument that they put forward. The last slide, why? Why is there no TCI in the United States? If the FDA were here, perhaps they'd like to explain it, because the argument as to is it a drug, is it a machine, is it a bird, or is it Batman, really was okay initially, but I don't think, N years on, they should have come to some deliberation. And I think we have to, as anesthesiologists and kineticists, be able to provide the best estimate for future uses of TCI, which provides the best kinetic model for adults, children, neonates, and the obese, and for any other patient groups where we think that there may be a significant variability in the kinetics and the dynamics of Propofol in order to affect the reliability of the present delivery systems. Thank you very much.